Good morning everyone. I'm Dr. Chandana from Department of General Medicine. So after an extensive case presentation and also case workup, we actually have many questions unanswered. As you said, sir, actually the case hasn't ended yet. There are many questions which are left unanswered. Maybe I'll clear a few of them, but that may make you more confused. So this patient, after workup, we are standing in the center of the slide with many differentials in our head. So going one by one, initially the patient was suspected to have autoimmune spectrum of disorders along with nutritional deficiency. He was treated for both of them, and later due to progressive splenomegaly at outside hospital, he was also treated for tropical splenomegaly and NCPF came into the picture. And later other differences like common variable immunodeficiency and Roseney-Troutman were also considered in between. But in the end, the biopsy report came out to be likely storage disorder and NCPF. This is the brief workup. So initially, vitamin B12 deficiency and iron deficiency was considered because many patients with vitamin B12 deficiency present with pancytopenia and splenomegaly. And vitamin B12 deficiency, the response to the treatment is the main diagnostic feature rather than any blood investigation for B12. So he was given empirically B12, but there was no adequate response. And oral iron therapy was also given for 6 months in view of few pencil form cells and few microcytes in the smear. And the next one is hyperreactive malaria splenomegaly. As India is an endemic country for malaria, in patients with massive splenomegaly, this differential should be kept in mind always. And the diagnostic criteria for hyperreactive malaria splenomegaly is exclusion of other causes of splenomegaly, which is like impossible practically, because unless it is histopathologically proven, we can't exclude other causes of splenomegaly. And the next criteria is immunity to malaria, which is defined as strongly positive antibody test, and splenomegaly of at least 10 centimeters, and a serum concentration of IgM, which is 2 standard deviations above normal, and clinical and immunological response to malaria. So keeping in mind the unexplained splenomegaly, outside hospital the patient was treated with primaquine, artemether and imifrantin, but there is no response. So this differential is out of the BC. And then due to massive splenomegaly, thalassemia was also considered in the initial workup, and there was normal hemoglobin electrophoresis. These thalassemia patients usually are fine till 6 to 9 months, and they develop severe anemia at 6 to 9 months because that is when the HbF switches the synthesis to Hba, and they present with failure to thrive, recurrent infections, and usually die within 4 to 5 years. And these patients have splenomegaly because there will be extramedullary hematopoiesis going on, and they present with microcytic hypochromic anemia and increased HbF levels, and they require repeated blood transfusion. And this diagnosis is ruled out in this patient. And pancytopenia with massive splenomegaly, hematological malignancy should be kept in mind. And in this patient, bone marrow showed reactive marrow, which rules out conditions like hematological malignancies, MDS, myelofibrosis, and lymph node biopsy was done to rule out lymphoma and lymphoproliferative disorders, which showed reactive lymphadenopathy. So that is out of the differentials. And coming to autoimmune spectrum of disorders, so coming to his childhood history of 6 months of diarrhea, back then doctors suspected it to be celiac disease, and they have even sent the endomycin anti-endomycin antibodies, but the report is not available with us. And also autoimmune thyroiditis, which is proved with antithyroglobulin antibody positivity. And then autoimmune hemolytic anemia, when the patient presented to our hospital with anemia, hyperbilirubinemia and DCT positive. So underlying autoimmune spectrum of disorders is always considered in this patient during his workup. And also our suspicion of autoimmunity has gained strength when we have reviewed the literature and found that there is an association of autoimmune thyroiditis with NCPF, and there is an association of common variable immunodeficiency and CVID with NCPF and autoimmune hemolytic anemias. So autoimmune hemolytic anemias and CVID came into the list of differentials. Coming to the autoimmune hemolytic anemia, when he was admitted, he had anemia, hyperbilirubinemia and direct womb test positive. So autoimmune hemolytic anemia is an acquired disorder where there is destruction of red cells. due to red cell autoantibodies. And he was treated with steroids, and there was a transient response, but later again patient again presented with pancytopenia and splenomegaly. That is when we have considered hypersplenism in this patient. And coming to CVID, common variable immunodeficiency was considered because the patient had childhood history of recurrent cold cough, and there is autoimmune hemolytic anemia associated with CVID, and there is known association of CVID with NCPF leading to hypersplenism and pancytopenia. So CVID was considered, and immunoelectrophoresis was done, which was normal, and ruled out CVID. Later, Rosai-Groffman came into picture when the inguinal lymph node cytology was looked like histiocytosis. And in Rosai-Groffman also, the sporadic variant of Rosai-Groffman is associated with autoimmune disorders. So this differential is still considered in this patient because patient has generalized lymphadenopathy, and these patients usually present with massive painless cervical lymphadenopathy, and there is 40% patients have extranodal involvement, and spleen is an infrequent site. It is a rare disorder where Rosai-Groffman is associated with splenomegaly. So this can be still considered. So as there is severe hypersplenism and pain abdomen, the doctors have decided to remove the spleen out and look at it. But spleen and liver biopsy in our hospital turned out to be storage disorder, and liver biopsy which was sent out outside hospital turned out to be non-cirrhotic portal fibrosis. So non-cirrhotic portal fibrosis is a disease with increased portal pressures due to portal vein fibrosis, periportal fibrosis of the small and medium branches of the portal vein, resulting in portal hypertension. The features of NCPF in this patient were enlarged spleen and dilated portal vein, but there are no varices and no ascites. But NCPF patients usually present with massive splenomegaly and well-tolerated episodes of recurrent hematemesis due to varices and anemia in young adult age group. But jaundice, ascites and hepatic encephalopathy are rare in NCPF. As the spleen is removed, so the portal pressure now may get diverted into the other compartments and result in esophageal varices in future. So we have counseled them that we'll take care of him in future if anything happens, and before splenectomy also. And then coming to his storage disorder, many questions remain unanswered if it is storage disorder. The first thing is which storage disorder fits in better, and the second thing is what should be the next step of evaluation, and what should be the line of management. If it is storage disorder, why does he have underlying autoimmune phenomena occasionally going on, and also why the liver biopsy turned out to be NCPF. Keeping in mind the family history of patient, storage disorder can be considered. But before splenectomy, our clinical diagnosis was mainly, rather than storage disorder, it was NCPF before splenectomy. So splenic biopsy showed foamy cells with vacuolated cytoplasm, which is seen in lysosomal storage disorders such as Niemann-Pick's. But there are so in Gaucher's disorder also, the foamy transformation of in Gaucher's disease also there are some case reports showing foamy transformation of the cells with number of vacuoles in the cytoplasm. So Gaucher's can also be considered. And if we suspect other storage disorders like Tay-Sachs, the death usually seen in 2 to 4 years of age. Mainly there will be no hepatosplenomegaly in Tay-Sachs, so that is out of the differential list. And coming to Niemann-Pick, hepatomegaly will be more than splenomegaly in Niemann-Pick's disease, and there will be neurological decline which is not there in this patient, and death usually occurs in 3 years of age. So Niemann-Pick is also out of differentials. And Fabry's disease, which presents with angiokeratomas, corneal opacities, nephropathies, cardiac disease, all these are absent in our patient. So Fabry's disease is not considered. Type 1 Gaucher's better fits in this patient, non-neuropathic type, where splenomegaly will be more than hepatomegaly. There will be anemia, bleeding tendencies due to thrombocytopenia, and repeated abdominal pains, But one thing is not there in our patient is skeletal pain and deformities, which is usually seen in Gauchers. So Gauchers and autoimmunity, there are some case reports where Gauchers is associated with autoimmune diseases. The link which is there here, there is a case study where 33 patients of Gauchers disorder are studied, and out of which 8 patients presented with lymphoproliferative disorders and 15 out of the 33 patients presented with autoimmune phenomenon. Later they are diagnosed with Gaucher's disease. So Gaucher's disease and autoimmunity, there is an association. And Gaucher's disease and massive hepatic fibrosis, even though they have reported it as NCPF, the portal hypertension can be due to Gaucher's itself. Gaucher's in some patients cause advanced confluent fibrosis occupying the central region of the liver. So portal hypertension can happen with Gaucher's itself. And Gaucher's, why no bone involvement is, there are some case reports where skeletal manifestations are seen only in advanced stages rather than all patients. So Gaucher's can be there without bone involvement. But the questions are, if it is Gaucher's, why didn't we see any Gaucher cells in the bone marrow biopsy or aspiration? And if it is Gaucher's, is there any need for repeat bone marrow? And what will be the next step of evaluation? Any enzyme assays that we have to do to diagnose Gaucher's? And any storage disorder other than Gaucher's that can be considered? If any ideas from you people, that will be most welcome. That will be helpful for further evaluation of this patient. So I think I have cleared few of your doubts, but I have left you with many unanswered questions.
Thanks a lot for this, Chandana. Let's give her a big hand.
What is the enzyme you want to see?
So there are glucosyl, sphingosine, and also chitotricoside.
So why not let us go ahead and do for the patient as well as the parents. It may be of some help.
Enzyme screening, like there is less sensitivity and specificity. So genetic analysis is more diagnostic, but we can screen them with the enzyme assays.
So how expensive would be a genetic analysis?
Cost 25,000.
Yeah, so that's a lot of money. 25,000 is what we did the surgery for, even less than that. So that again, I think Akim is listening in. So those are the issues, I think, in terms of what we were talking about, what Akim talked about. And yeah, so other questions from the audience? Yeah. Dr. Sadhana is here with us, and yeah, I'm handing over the mic to her.
I congratulate the Department of Medicine for this kind of approach to the patients, very new change for all of us to learn. I am Sadhana Sharma. Dr. Rakesh has introduced me as professor. I don't consider myself as professor. I consider myself as a student. So today also I have come as a student, as a learner, to learn from all of you, and I will continue to remain so. Now, when I went through this, I tend to, a part of child still remains in me, in the sense that when your mother shows you that, when you are 3 years old and mother says that this is a snake, this is not a rope, but you still tend to say, no, this is a rope, this is not a snake, right? The same way the 3-year-old in me doesn't die. And I tend to, though you have given 200% your history, I would still like to have certain things to be asked for. There have been siblings who have been affected with this kind of illness. So yeah, so when I was going through it, and when I saw his recurrent hospitalizations, his history of diarrheal illness, pancytopenia, anemia, and when I saw that you also had entertained the possibility of celiac disease, I too was slightly deviated towards that. But why not celiac disease? Because you had not got the report of anti-endomycin antibodies, right? So we didn't have anything to either negate or to say positively that this was celiac disease. So we were in a limbo then, we are still in a limbo, that's what I feel still. Despite getting 2 contradictory pathological reports. Had we got a concurrent pathological report, maybe I would have been more sure to negate celiac disease. Why I am saying this is, when I was going through all these things, I was finding that there is a lot of, it's not just positive thought, or probably we don't want to entertain that rare diseases are there. They are not as rare as we are taught to or as we think, right? So we have been, like in our traditional medical teaching, we have always been taught that you think of common things first. Yes, we are right in that. There's nothing wrong in it. But that doesn't mean that with the better availability of the facilities, with the better diagnostics which is available now, we should not divert our thought process to that spectrum as well, right? So did you go into depth of analyzing it? That could it be celiac also? I mean, just 2-3 tests more, right? Some serology to just rule that out. Since we have now two conflicting, not conflicting, as Dr. Rakesh he just told at the beginning, that we are entertaining NCPF, we are entertaining Rosai-Dorfman, and we have Gaucher's. Right, so it is Gaucher's, it is Rosai-Dorfman, or it is NCPF. This is still again a confusion. I think, had I been there, maybe if I had the patient with me, would I have got some extra information on examination or on history, which would have probably provoked my thought process in another fourth entity as well. Since we are saying that it's not that uncommon, and we are seeing lots of them which present with the same kind of picture, right? It presents with the celiac presentation is also more or less like this. Now coming to Gaucher's, when you are saying that we have these foamy vacuolated cells which are there in the marrow, so your question is whether should we go ahead with a repeat marrow, right? I think that's what you wanted to say. But then when I surf the literature, I got some studies for you, is where they say that bone marrow is not mandatory at all for the diagnosis of Gaucher's, right? So you would have, like it was mentioned, where do we see these infiltration of the Gaucher cells more? We usually see it in the long bones, in the pelvis, and it is in the proximal and the distal end, which is more. So previously they used to say you just go ahead with the conventional radiology and take the X-rays of the bone mass, of the long bones, and maybe we could see some enlargement of the metaphysis or the diaphysis there. Epiphysis there. So now we talk about whether should we go for MRI of the bone, right? Can that pick up infiltration? Secondly, if bone marrow, maybe the conventional bone marrow biopsy may not pick up the regular routine pathology, may not pick up the foamy cells, but do we go for nuclear scan, like technetium systemically scan? Where is it available? Should we? And then your biomarkers, the novel biomarkers. Where do we have those biomarkers? Now regarding the sensitivity and specificity also, we are not still sure. There are studies, but nothing has said that there is even 98% or for that matter above 90% sensitivity or specificity of some of the markers. Where do we get these markers done? Right. So it is flow cytometry on the monocytes or the mononuclear cells. So where are the facilities available for this? Because again, these are the diseases which have been very well studied in the West. They have been researched very well in the West, where they have gone even up to treating such patients. Now we are in a stage, forget about treating. We are still in a stage, and it's wonderful. I must applaud all of you that you have started thinking about those. And you have started, you have diverted your attention that no, we have to see through that, which West had been doing from the very beginning, because they thought we were focusing only on infections till now, right? We never had time, we never had resources to take ourselves away from infections and NCDs to these kind of illnesses, hereditary diseases, because they didn't make the major chunk of our health system, right? So we always we are those conservative people where we always tend to see the cost constraints and the time, because we are burdened with lot of patient population. So what we see is when we are taking care of those patients, somewhere down the line, we have a stepmotherly or stepfatherly treatment for such kind of cases, right? We were tending to leave them on fate. We just used to have theoretical discussions and it used to stop at some particular juncture. Now, not taking much of the time. What I feel is these are the new things, these are the investigations we can think of. But coming back to the financial status of this patient, how do we solve it practically? So, if we come to know, say we have the diagnosis of Gaucher's, right? We have the diagnosis, after that, we have to give them a treatment. Can they afford the treatment? Secondly, does it add to the anxiety of the patients and the patient's relatives and the patient himself? Because we have seen, after doing all those so-called genetic studies, we have started prenatal screening up in the West, right? And has it served purpose? For some of the cases, we saw that these are the patients who had almost asymptomatic life throughout their history. But then we had given them a anxiety throughout life that one fine day I will develop the disease. They might not have. Had they been aware? Had they been ignorant about it? Was it a blessing? Right. The other point of contention is, if we know it, we are careful in monitoring. In case they develop the disease, we have a therapy to treat. So considering our socio-cultural milieu, how far are we justified? These are the questions which I was pondering. How far are we justified in subjecting them to all sorts of investigations? Academic purposes, research purposes, yes, we have to do it, otherwise we won't get answers to so many diseases. If we see the other angle of it, are we justified? I still say we are justified. Institutes like us, these are not the diseases which are very common. We can have a corpus. We can have a corpus where we can take care of diagnostics and therapeutics of such patients. So I think these are the things which Dr. Rakesh, for this patient, you will have to think about, and that's how we go ahead. I think that's.
Dr. Chandana, there, our faculty, she wants to ask a question. But I feel like an excited student after she said all this. I feel like I would like to answer her question first before giving you the mic. So, or maybe Chandana will. So, yeah, you raised a very interesting point about the celiac and what did we do for that celiac autoimmune? Because right after this, we have got somebody from Kakatiya Medical College presenting on autoimmune Crohn's disease, and that's why I wanted it to kind of come in line with that. And actually, Raveen in his presentation in the case report, he had mentioned that the patient's diarrhea improved remarkably when he stopped eating wheat.
Exactly, that was there in my mind when I was analyzing.
Yeah, so clinically, this was fitting into celiac. Of course, now as you raise the other point as to how much benefit one can draw from having a more, a chemical diagnosis. Like let's say we do the anti-gliadin antibodies, and we say, oh, now it's 95% sensitive specific. But why not just the fact that yes, he became all right with by removing wheat from his diet. So I feel I would like to think that he definitely had a autoimmune celiac disease along with his autoimmune thyroiditis, beyond doubt. And very interestingly, he may be having some autoimmune thing going on in his portal vein, the third or fourth radical of his portal vein, if not for Gaucher's, which is also intruding in this thought process. So with this, I would give the mic to Dr. Chandana. Where are the other mics? Just please.
Dr. Vishwas, I would like to just, Madam have very nicely described all the things to be ruled out and what can be done, what not can be done. But in the diagnosis, actually, we give utmost importance to the pathological diagnosis. See, once the pathologist has confirmed this is a Gaucher's disease, I don't think there should be so many queries and all on that.
No, the pathologist hasn't
See,
confirmed this.
they have confirmed foamy cells and everything present. They beyond doubt is confirmed. Such a huge spleen is given. If we still have doubt, we can take second opinion, third opinion like that. But I feel that is the main problem. But we have to attribute various other, symptoms. What he is having. Are they possible to be associated with either Gaucher's or hypersplenism?
Yeah, I mean.
Is it ruled out? Gaucher's disease is ruled out now?
No, it is still in limbo, as they call it.
The HOD pathology is very clear. It's beyond doubt. She said it is. So once the pathologist gives the final diagnosis, and we can only check up from other second opinion we can take, and even Gaucher's disease also some amount of fibrosis can be there in liver, which might have been erroneously given by cirrhosis of.
Yeah, I would agree with you that pathology, structural anatomy, we often think of these as structural, invincible and immovable things, whereas physiology is more like changes with time. So when we say pathologic diagnosis, it is like formalinized and it has been completely paraffinized and it is the diagnosis. But here we are dealing with complexity where there are two pathological diagnoses, and as you rightly said, there could be multiple reasons for it. And I don't know where is the pathologist.
One, I feel Gaucher's you have to keep in mind. Second, autoimmune element like telling celiac, then
if we go by the
hyperthyroidism, all those things.
Yeah, the sequence of events. Yeah, the sequence of events has suggested that there is a immune-mediated process which is going on, and this immune-mediated process is very dynamic. And if you think of Gaucher's, it is something genetic which has happened due to a protein molecule being generated through that faulty gene. Nothing can really change there. Once a Gaucher's, always a Gaucher's. Now here it's a very dynamic process. So that is why. We'll move to Dr. Chandana. She's been waiting here.
Sir, I just wanted to tell regarding Gaucher's disease, as Madam told, it is like the sensitivity and specificity for the enzyme activity is very less. So what I think, ultimately the pathology is the ultimate diagnosis. So biochemistry also plays a role. Like we can send, if the patient is affordable actually to say, to confirm if it's a Gaucher's disease, NIMHANS in Bangalore, which is it's a central institute, they have a tandem mass spectrometry, which is really diagnostic. They can pick up beta-glucocerebrosidase, which is the enzyme deficiency there, and the sensitivity and specificity with flow cytometer, it is much more higher than this flow tandem mass spectrometry. Usually what they do is all over India, they send the dried blood spots through mail or something, and they remove it, the dried blood spot, and they process it, and then they give the result for inborn screening of metabolism so in case if they can go, it's a central institute, maybe they can give it at a very reasonable price if they want to confirm it is a Gaucher's disease, and they can go for genetic testing also there in NIMHANS, which it can, if the patient is affordable to go there and get the treatment.
Yeah, as Madam was saying, the practical issues, like, unless we have a connect, again, I think Akim was talking about interdependencies, interconnectedness. Unless we can send this sample ourselves, now the patient only cares. Professor Krishnamurthy has done the best thing for him. He has removed the spleen and he is the happiest person alive. This 14-year-old boy, he has made Raveen his mama, and that's what we are used to being a doctor. So that is one aspect. But now we are thinking of the disease. We are not thinking of that person now. We are thinking of his spleen, his liver, and we want to get to the bottom of this the scientific things which have been discovered in the past. So is that practically useful for that boy? I think that's what Madam also meant, Hakim would also mean. And if it is not, then isn't it ethically our responsibility, as Madam said, to raise some funds and get it done ourselves? Why put the burden on the patient for our learning? I think that is an important point which I think all of us may agree to. And if we know someone, it's an academic thing, we should be interconnected. We can send it through that proper channel instead of putting the burden on the person per se. So, yeah. Yes, Dr. Rajkumar, you have something? Yeah. Oh, yes, Hakim wants to. Okay, yes, Hakim.
Well, I think one point you made is really quite important to take into consideration. Medicine has developed or has remained stuck on the anatomical manifestation. And if you take a historical look at how medicine developed, Leonardo, for all his brilliance, is a culprit. He has shown how the body, what the body looks like in anatomical terms. If you then look at the pathologists at the time, they described the seat of disease, staying anatomical. We had the development of the microscope, and you could see the disease-causing features of the largely infectious diseases of the 18th and 19th century. And then we developed X-ray to look at the structure of disease or at the seat of disease in the living. We had Rokitansky as one of the leaders of the clinical pathological methodology, correlating the symptoms of the patients with the anatomical changes that you can see with your eyes. But much of what is happening, and you alluded to it, this patient got better by leaving meat away. You don't need anything more. You want the patient to be better and feel better, even if you don't have an anatomical correlation to what's going on. You still have learned something, and you have made a valuable inference on what is behind the patient's illness beyond the identifiable, or in this particular case, not so readily identifiable pathology. So again, to me, that is pragmatic complexity thinking at work. And we need to remind ourselves when we get stuck on these fine things of is a test sensitive and specific enough? Is what we see under the microscope really what is defining the disease? There's doubt about many of these kind of things. But what we can observe is dynamic change over time. And we need to have the confidence as physicians, as healers, to say, okay, what we have done has worked, we don't know really why, but it doesn't matter. That's the academic side of it, where then sort of people like me, who now has time to think about it, can contribute after 40 years of experience in the clinical field. But I think we need to develop the true confidence of saying complexity is not always understandable, it is observable, it is describable, and it's understandable, even if you don't necessarily know all of the mechanistic features of the interactions that are going on. My two box first.
So another round of applause for Hakim. So, yeah, Dr. Rajkumar.
Yeah. Professor Hakim excellently said. I have another question. When you are dealing with the complexity and the factors which are, we are dealing with the unknown factors, what kind of thinking is required? Is it slow thinking or fast thinking? Sometimes, that fast thinking part, which comes from the mammalian brain, how do we shut down sometimes for the neocortex to take over, so that So my question is, how to, what is the best form of thinking in dealing with the complexity, whether it is slow thinking or fast thinking, or what kind of thinking is required?
Well, fast thinking is very simple. It's stop diagnosis. That goes with fast thinking. All the rest goes with slow thinking. So if you have the three key features that make a diagnosis, then fast thinking does very well. But if you consider this particular case, you don't have any three features that give you a diagnosis. You have several two-feature things that may hang together, but the third thing that is necessary to come to a clear-cut diagnosis, you haven't identified. And the process of your discussions at the moment is really to ask many different brains, can you identify the third thing that is missing, so that we can close this case with a definite answer. As things go in a Pareto distribution, you may end up being the 0.8% where you never find the answer. And this is part of the resilience we need to develop as physicians, to just say it's okay. Not everything we can explain, but we can give it a good shot. And if we are able to put the issue into its broader context in which it is contained, then we have done the required job properly. If we forget about that, then we fail. We fail ourselves as well as failing our patients. So that this boy is really happy and that the family is really happy, I can fully appreciate from a systems and complexity perspective. He now can live a relatively normal life. There's still a few hitches, but he can cope with that. He has come to terms with it, which is sense making about what is going on, and also accepting that he has now a big line on his belly that he has to live with for the rest of his life. That he may have restrictions in taking part in family gatherings and has to eat something somewhat modified to the rest of it, the others. This is all part and parcel of healing. And that is what it's all about. Healing can be achieved without knowing what the problem is by categorization. Keep in mind, disease is a categorization, it's a classification. It's not an objective entity. It's socially constructed. We have given it that name. It's helpful because it helps to streamline our way of thinking and acting. So if you don't have that for all the common diseases, we would not get anywhere, and lots of our patients would succumb to otherwise simply treatable conditions. It is what I said earlier. You need fast thinking and slow thinking simultaneously. And that is something that the younger colleagues that I've seen on the screen have to learn, where you as the more senior people have to remind them. That's the teaching part of it. And you, because much of what you and I have as experienced clinicians is tacit knowledge. You cannot really talk about that in a translatable way, like you can talk about the thing you pull out and call a femur. This is a femur. That you can teach that if you show them the bone. But to teach them of what it means to be that 14-year-old boy, you can have hunches of it, and you can point it out based on your tacit knowledge. But it's very difficult to describe it in objective, teachable fashions.
Excellent. Thank you. Thank you so much.
Pardon me for asking this question. I am Dr. Krishnamurthy, the professor of surgery. Once Dr. Rajkumar has raised this doubt about fast thinking and slow thinking, I just wanted to clarify. So the age we all become slow thinkers. Now we are touching around 70. We have become slow thinkers. So what I understand is probably fast thinking and deep thinking. The other one is probably deep thinking. What is meant more appropriate? Of course, you are the native English people. You can choose the correct terminology. What I understand is because we all become slow thinkers now, and our slow thinking is we giving decision little delayed decision, but it may not be deep thinking.
Thank you. I fully agree with you. But if you start to think more slowly, you also start to think more in depth. So you cannot think in depth fast.
Also, sir, on a lighter note, the patient is actually having quite a normal lifestyle at the minute. His father is a meat vendor, and this boy personally likes to have meat. He's been consuming it for the past 2 months, and he's actually doing good.
Good.
Yes.
Wonderful.
Yeah, he was asking if he can have biryani on POD4. So we just told him he can do that after he goes home because he had that and he's doing quite well.
So I think Dr. Rajkumar, you mentioned a very nice this thing, and on this note, I remember a very good a survey was done in Afghanistan, and it was done amongst the physicians. So they had taken the youngsters who had just finished their medicine course, and then there were these in between, and they were around 50 and 60 years old who were quite experienced. So this was regarding the knowledge of celiac disease, and in that they found out that the most aware, it was actually a survey of awareness. So the most aware were the physicians who had just passed out their medicine, because they were so bubbling with their theoretical knowledge. So they wanted to keep, their horizon wide, and they wanted to entertain lot of things in their differentials. While the middle one, they had forgotten. They had forgotten it because they were in the, they got caught in a web where they were used to the day-to-day practice, the day-to-day diseases. And then it was in a higher, above 50 or 60, because they had this experience. So by this time they had reached where they had seen the common, they had seen this, and again it had come back to them that yes, we have to keep it in the mind itself. So I think what is important is, as Krishnamurthy sir said, it is deep thinking also. So we have to keep all the thinkings along with it, along with our the common sense, that which should take priority, right? In which patient. So we always say individualize, individualize, individualize. We always talk about therapeutics when we are talking about individualizing. If the individualizing is with the patient also. I think that is what is very important.
Thank you one and all for all your inputs. That was really.
Yeah, and we had this modular session since morning 7 a.m. We have started with autoimmunity, and the first 2 sessions were rheumatology. So we had lupus nephritis, then we had a lupus catastrophic, and then we had a very interesting biopsychosocial model which was fitting into the catastrophic lupus, where we kind of tied it up. Then we had Dr. Akim's keynote speech on complexity, and after this we have this module of probably non-rheumatological autoimmunity. If you look at this boy with thyroiditis, celiac disease possibly, and something in his liver and spleen, and autoimmune hemolytic anemia. Yeah. So we wanted to finish this module with a wildcard entry. Actually, even Dr. Supriya's was a wildcard entry. We had, if you look at the schedule, you find that many of them are not in that schedule. So we have kept an open window for wildcard entries also. The schedule is actually made by the speakers who are experienced postgraduates who have done 2 years of research on the topic that they are presenting, like Dr. Chandana, Dr. Ravi, and many others who will follow. But the wildcard entries are those who have, some insights to give us. And I must say, Dr. Supriya's contribution insights were astounding. And similarly, we have got a very, very interesting person here who is a first year medical student from a very prestigious medical school. And he has come, he hasn't even started anatomy physiology because he's just entered. But he is a patient advocate. So he is going to talk about a patient who he knows as a person. That is what we were looking for. All the while, he would know in and out of this person that he is going to talk about. Although as a first year medical student, he would again like to probably focus on the disease that we discussed. And yes, so I would like to invite Dr. Dikshit, the first year medical student.
So, and I made a funny case series that is displayed in the